Wache, and welcome. This is Anne from the Sioux Lookout Practice Consultant Team, and you're listening to the Practice.Support podcast, the one and only show that discusses new practice updates and changes for ISC's Ontario region. Coming to you with acknowledgement to the Anishinaabe Algonquin Nation, whose traditional and unceded territory this podcast is recorded on, and with respect to the different traditional Indigenous territories of Turtle Island that this podcast may find you. All right, today we're talking about refusal of care with NPC Liz Wallace. Welcome, Liz.
Hi, Anne. Thanks for having me here today.
So, you wanted to talk about refusal of care processes today. Why has this topic come up for discussion?
As a practice team, we've been getting more questions lately regarding what to do when clients either want to leave the clinic against medical advice or are declining care in some capacity.
So what do you think has prompted this increase in questions?
I think a lot of this is related to some of the changes to the clinical practice guidelines lately that have led to consultation for all episodic clients. It can lead to clients being in the clinic longer, awaiting callback from the MD or MP, and some clients may want to wait at home or just leave altogether.
So what are some key points you would want people to know about these situations?
I think number one is that any client that has the capacity to consent also has the capacity to decline care and make decisions about what is happening to them and their body. But similarly to consenting for care, refusing or declining care must also be an informed process. This means that the client must understand the risks, the benefits, and the options and alternatives available when making that choice.
Those are good points. What else should be considered in these situations?
Number two for me is that we always need to be putting clients first in this process. We need to be considering systemic barriers that our clients face in being able to accept treatment. So these can be things like past traumatic experiences in the clinic, pain, hunger, a fear of leaving the community for treatment, language barriers, childcare issues, or fear of procedures. We need to work with our clients to help explore if these are the reasons they're refusing care, or work with them to help navigate some of these issues.
These are excellent points to think about, Liz. Are there any other factors you wanted to highlight with this process?
Another point I wanted to make is that just because someone is declining care at this time doesn't mean that our duty to provide care ends or that someone is unwilling to continue their care. We need to remember in some instances like CTAS 4s or 5s that are stable, it can be okay if a client does want to wait at home or go and grab a coffee or some food. The CHIN responsible needs to ensure that the client understands the plan of care, when to return, so discussing those red flags, and have a method of contacting that client. In these instances, these aren't refusal of care. Also, we need to remember that when the client has left the clinic or declined care, we still have an obligation to engage our clients in care and follow-up. So this includes consulting the MD or NP after a client has left to be able to bring this information that we found in our assessment and come up with a treatment plan so that we can bring these back to the client to continue that informed decision-making process.
So if the nurses wanted to read up more on this, what resources should they turn to?
My favorite thing, policies. I know everybody's bored by them. So in this case, policy 2-32, which is refusal of care, outlines everything nurses need to know in this process. Number one, nurses need to provide the client with all the pertinent information about the procedure, so risks and benefits, so that they're making an informed decision. Sometimes this means you can advise the client to talk to the MD or NP or bring in a second CHIN before making this decision. Sometimes it may mean bringing an interpreter to navigate some language barriers. Also, clients can refuse this option to have a second provider brought in. Once the decision has been made to decline care, the policy outlines that a second CHIN must be there to witness the refusal and that they have witnessed the primary CHIN describe to the client the risks and benefits, the possible alternatives, and they've witnessed the client refusing acknowledging these risks. It should also be made known to the client that they are welcome back at any time and that we are going to be continuing in this process. In the chart should be the primary CHIN documenting all of the above. So again, risks and benefits, alternative options, the client's refusal, and the client's understanding of the consequences, and the instructions if the client changes their mind. The witnessing CHIN should also document this in a separate note and any additional findings they want to add. The practice team is aware that situations where a client declines or refuses care can be confusing to navigate, so feel free to reach out to discuss these at any time.
That's excellent. Thanks for bringing up refusal of care policy and situations where clients decline care. It's a really good topic to cover.
Thanks so much.
Thank you all for listening to the Practice Support Podcast. If you're keen to follow up on any of the information you've heard today, head on over to One Health and iTacit, where you'll find more links and resources. For more practice updates, don't forget to find and follow us on our Instagram, Facebook, and YouTube channel at SLKT.Nursing.Practice.Support. And as always, if you have any questions, please reach out to a nurse practice consultant, an education practice advisor, or your manager. That's all for this episode, folks. See you at our next podcast.